Welcome back to the deep dive. You know the drill. You send us your study materials, notes, whatever you've got.
And we dig into them, pull out the absolute must-know stuff, and get you up to speed quickly.
Yep, it's your fast track to, well, knowing your stuff. Today we've got some revision notes someone sent in.
Right, focusing specifically on Factor V Leiden deficiency. So our aim here is clear, high-yield information, perfect for revision. We want to make this really stick.
Okay, let's unpack this then. Factor V Leiden. So in simple terms, it's what? A genetic thing. Makes blood clots more likely.
That's the gist of it, yeah. A genetic variation that increases your risk of forming blood clots when you shouldn't.
Okay, and we're going to cover the whole picture, right? Definition, causes, risks.
Exactly. Pathophysiology, how it works, differentials, who gets it, how it shows up, tests, management.
Who works, prognosis, complications too. Look, medical stuff can feel heavy, we know that.
But we'll keep it clear, manageable. Promise.
All right, so definition first. Lay it out for us.
Okay, so Factor V Leiden, fundamentally it's a genetic mutation.
Yeah.
And the core problem is it bumps up the risk of abnormal blood clots forming.
Right.
And here's a key thing for revision. It's actually the most common inherited thrombophilia.
The most common tendency to clot that you inherit?
Exactly. Thrombophilia just means that tendency to form clots, and this one's inherited.
Gotcha. And the genetics. You said a mutation.
Yeah, specific point mutation. It's in the gene that codes for clotting factor V, and it's passed down in an autosomal dominant way.
Autosomal dominant, meaning?
Meaning you only need to inherit one copy of that altered gene from either parent. That's enough to have the condition.
Just one copy. Wow. And it's common, you said?
Surprisingly common. Yeah, especially people of Caucasian background. We're talking around 5% prevalence.
5%. That feels pretty high for a genetic condition. So what does that mean in terms of actual, clot risk?
Good question. So if you have one copy that's heterozygous, your risk of a blood clot, a VTE, is roughly 3 to 5 times higher than average.
3 to 5 times. Okay.
But if you inherit 2 copies, one from each parent, making you homozygous, that risk jumps significantly, maybe around 8 times higher, or sometimes quoted even higher.
8 times?
Yeah. It creates what we call a hypercoagulable state. Your blood is just stickier, more prone to clotting, particularly venous thromboembolism, VTE. So the DVTs, PEs.
Deep vein thrombosis and pulmonary embolism. Okay. But your notes also mentioned the risk isn't, guaranteed.
That's a really important point. It's not absolute. Having the gene increases risk, but it's not a certainty you'll get a clot. There's this thing called penetrance.
Penetrance.
Yeah, it's basically the likelihood that having the gene will actually lead to the condition showing up. With Factor V Leiden, the penetrance isn't 100%. Other factors matter too, lifestyle, other genetic factors, circumstances like surgery or pregnancy.
Right. Okay, so it's a predisposition, not a destiny.
Exactly. And it's worth noting, while the risk is increased, it's generally considered lower than the risk you see with deficiencies in other natural anticoagulants, like protein C, protein S, or antithrombin III. And one last clarification. Factor V Leiden is not the same as Factor V deficiency. That's called Ahrens disease. It's rare, and it actually causes bleeding problems, not clotting. Totally different thing.
Got it. Good distinction. Okay, maybe a little memory tip here for everyone listening. Factor V, fighting clots. Leiden means they're not fighting so well, or maybe fighting too much in the wrong way, leading to clots. How's that?
I like it. Helps frame the core issue. So moving on to the cause, the etiology.
Yeah, what is the root cause here?
Well, as we said, it's that specific mutation in the Factor V gene. Remember, Factor V is a protein that helps blood clot.
Right.
The mutation changes the Factor V protein slightly, and that change makes it resistant to being switched off by another protein called activated protein C.
Activated protein C sounds important. What does it normally do?
It's really important. Activated protein C, or APC, is one of the body's natural anticoagulants. Its job is to put the brakes on clotting. It does this mainly by breaking down activated Factor V, stopping it from contributing to more clotting.
So APC is like the off switch.
Exactly. That's a great way to put it. It helps shut down the clotting cascade once it's done its job. But in Factor V Leiden, because the mutated Factor V is resistant to APC.
The off switch is kind of sticky. It doesn't work properly.
Precisely. The off switch doesn't engage properly with this mutated factor. So Factor V stays active for longer, leading to more thrombin generation, more fibrin formation. Essentially, the clotting process doesn't get dampened down like it should.
Which means higher risk of clots.
Higher risk of clots. That's the direct link.
Okay, that makes sense. The sticky switch. So risk factors. You mentioned inheriting the gene is the main one.
Absolutely. The primary risk factor is having the genetic mutation inherited from one or both parents. So family history is a big clue.
Yeah.
If you have relatives with Factor V Leiden or a history of unexplained clots, especially at a young age,
Then your own risk might be higher.
your risk of carrying the gene, yes. And therefore, the increased underlying risk for clots.
Right. Okay, let's dig a bit deeper into how that sticky switch actually causes problems. The pathophysiology, you touched on it, but let's flesh it out.
Sure. So normally the clotting cascade is a carefully balanced process. You get an injury, factors get activated, factor V becomes factor V, which helps factor X convert prothrombin to thrombin, and thrombin converts fibrinogen to fibrin, forming the clot mesh.
Okay, the normal process.
Then activated protein C, APC, usually working with its cofactor protein S, comes in to regulate things. It specifically targets factor V and another factor, factor A, cleaving them, inactivating them. This slows down thrombin production.
The brakes.
The brakes, exactly. Now, the factor V Leiden mutation happens at the exact spot where APC normally cuts factor V.
Ah, so APC can't cut it?
It can, but much, much more slowly. It's resistant. So factor V hangs around for longer, keeps driving thrombin production.
Leading to too much clotting potential.
Precisely. More thrombin, more fibrin, a hypercoagulable state. And that's what directly increases the risk for those DVTs, PEs, the VTE events.
Got it. The sticky switch analogy holds up. Now, if someone comes in with, say, a DVT, how do doctors figure out if factor V Leiden is the culprit versus something else? What are the differentials?
Crucial question for revision. You see a clot, you have to think broadly. Yes, factor V Leiden is high on the list, especially if the patient is young, has a family history, or the clot happened without an obvious trigger like recent surgery.
Makes sense.
But you must also consider other inherited thrombophilias: protein C deficiency, protein S deficiency, antithrombin deficiency, prothrombin gene mutation. Those need to be in your differential.
Other inherited clotting risks.
Right. And then there are the acquired risk factors, things that aren't genetic but still raise clot risk significantly.
Like what?
Oh, things like being immobile for long periods, major surgery or trauma, pregnancy, using estrogen-containing pills or HRT, cancer is a big one, certain autoimmune diseases, even just being older increases risk.
So lots of possibilities.
Absolutely. You need a good history, examination, and targeted tests to figure out the likely cause or combination of causes. Not every clot is factor V Leiden.
Right. Good point. Okay, let's talk numbers. Epidemiology. You said about 5% prevalence in the UK.
Yes, around 5% in the UK Caucasian population. And this highlights a really key epidemiological point from the notes. It's way more common in people of European descent.
More common in Europeans.
Significantly so. Some studies show even higher rates in specific parts of Europe. But conversely, it's very rare, almost absent, in people of Black African heritage, Far East Asian populations, Native Australians, and Native Americans.
Wow, that's a huge difference. Why?
Well, the thinking, as hinted in the notes, is that maybe, just maybe, it offered some kind of survival advantage historically in European populations.
An advantage? How?
Possibly related to reduced bleeding, maybe less fatal bleeding during childbirth for women carriers. It's speculative, but it could explain why a gene mutation that causes problems later in life became so common. An evolutionary trade-off, perhaps.
Fascinating. Something to definitely remember about who's more likely to have it. So how does it usually present clinically?
Well, here's the thing. Many, maybe even most carriers of the factor V Leiden mutation actually never have a clot. They can go their whole lives completely asymptomatic.
Really? So you might not know you have it?
Exactly. You might only find out if you get tested because of family history, or maybe before a high-risk situation like major surgery.
Okay, but if they do get symptoms?
Then it's usually the symptoms of a blood clot, a VTE. Most commonly, that's a deep vein thrombosis, a DVT, usually in the leg swelling, pain, redness, warmth.
The classic DVT signs.
Yep. Or if a piece of that clot breaks off and travels to the lungs, a pulmonary embolism, a PE, that presents differently. Shortness of breath, chest pain, especially when breathing in, maybe coughing up blood, rapid heart rate.
Serious stuff.
Very serious. Less commonly, clots can occur in other places, like veins in the brain, abdomen, or arms. Diagnosis often happens after one of these VTE events, or maybe during investigations for recurrent miscarriage, which has a complex link.
Okay, so look for clot symptoms, but remember, many are asymptomatic. Your notes also mention something surprising. Potential advantages.
Ah, yes. It's quite counterintuitive, isn't it? While the main story is increased clot risk, There's some research, still ongoing, mind you, suggesting possible benefits for carriers.
Benefits, like what?
Things like potentially reduced menstrual blood loss for women, maybe a lower risk of certain types of brain bleeds like intracranial hemorrhage. There's even some suggestion of better survival outcomes in severe sepsis or acute respiratory distress syndrome.
That is surprising, sepsis survival.
Yeah, and maybe even milder kidney problems in diabetics, milder diabetic nephropathy. It's complex biology. Maybe a slight pro-clotting tendency helps control bleeding or inflammation in some specific contexts.
Oh, a real paradox.
It is. It shows how genes can have multiple, sometimes opposing effects. So, for revision, primary issue is clots. But be aware of the asymptomatic state and these potential, shall we say, silver linings, so they need more research.
Definitely a curveball to remember. Okay, so how do we actually test for it? Investigations.
The gold standard is genetic testing, a blood test looking specifically for that Factor V Leiden mutation in the F5 gene DNA.
Straightforward DNA test.
Pretty much. Before that, or alongside it, coagulation tests can give clues. There's a specific test called the Activated Protein C Resistance Assay, the APC resistance test.
How does that work?
It basically measures how much the clotting time of a patient's plasma is prolonged when you add activated protein C. If the blood is resistant to APC's anticoagulant effect.
Like in Factor V Leiden.
Exactly. The clotting time won't prolong as much as it should. It suggests resistance, which is most commonly caused by Factor V Leiden. If that test is abnormal, you'd usually confirm with the genetic test.
Okay. APC resistance test, then genetic confirmation.
That's the usual pathway. And of course, if you suspect someone has a clot right now, you need imaging ultrasound for a suspected DVT, usually a CT pulmonary angiogram, CTPA, for a suspected PE.
Right, to find the actual clot. And who should get tested? Should everyone?
No, definitely not. The notes are clear. Routine screening of the general population isn't recommended. Testing is usually considered by specialists in specific situations, like an unprovoked VTE, especially if young, VTE with a strong family history, maybe recurrent pregnancy loss, though that's debated.
So, selective testing based on clinical context.
Precisely. Guided by specialist assessment.
Okay. Let's say someone is diagnosed. What's the plan? Management.
Management really depends on the individual situation. Have they had a clot? What were the circumstances? What are their other risk factors?
It's not one size fits all.
Not at all. If someone has had a VTE, they'll typically be treated with anticoagulants, blood thinners like warfarin, or more commonly now, the direct oral anticoagulants, the DOACs. The duration of treatment depends. Was it provoked by something temporary like surgery or unprovoked?
Okay, what about people who haven't had a clot but know they have the mutation?
That's where it gets more nuanced. Generally, long-term anticoagulation just because you carry the gene is not recommended if you've never had a clot. The risk of bleeding from the medication might outweigh the benefits.
So, no automatic blood thinners for life?
Usually not, no. Management for asymptomatic carriers focuses more on awareness and risk reduction. Lifestyle things, staying active, maintaining a healthy weight, avoiding prolonged immobility.
Sensible advice, I need.
Exactly. And being aware of high-risk situations. If they need major surgery or become pregnant or have a serious illness requiring bed rest, then preventative anticoagulation, often with low molecular weight heparin, LMWH, might be used temporarily during that high-risk period.
Prophylaxis in risky times.
That's the idea. Also, important point about hormonal contraceptives, estrogen-containing ones do increase VTE risk, and the risk is higher in Factor V Leiden carriers. But again, routine screening before starting contraception isn't standard practice currently. It's more about informed discussion of risks and benefits.
Stem pregnancy. You mentioned LMWH.
Yes, pregnancy itself is a prothrombotic state. For women with Factor V Leiden, especially those who've had a previous clot or have other risk factors, LMWH is often used throughout pregnancy and for a period postpartum to reduce the risk of VTE. Management should always be planned with obstetricians and hematologists.
Okay, so if someone listening has Factor V Leiden and is planning surgery, what might they expect? That's a good revision question.
Good one. They should definitely inform their surgeon and anesthetist. Management would likely involve a risk assessment and probably prophylactic anticoagulation, maybe LMWH injection starting shortly before or after surgery and continuing until they're mobile again.
Individualized plan. Makes sense.
What about the long-term outlook, prognosis?
Generally, it's good. The key message for revision is that most people with Factor V Leiden can and do lead perfectly normal lives.
That's reassuring.
It is. The prognosis really hinges on whether they develop clots, how effectively those are managed, and managing other coexisting risk factors. With proper awareness and preventative strategies when needed, the outlook is generally positive. Good to hear. But there are potential complications to be aware of.
Yes, definitely. The main one is, unsurprisingly, recurrent VTE.
Okay.
Having had one clot increases the risk of another, and Factor V Leiden adds to that underlying risk.
Repeat clots.
Right, DVTs or PEs.
Yeah.
Also, the treatment itself, anticoagulation, carries its own risk, bleeding complications. It's always a balance between preventing clots and causing bleeding.
The treatment risk.
Exactly. And finally, just reiterating that increased risk during specific high-risk times, surgery, pregnancy, prolonged immobility, these periods require extra vigilance and potentially preventative measures.
Okay, so maybe a provocative thought here for revision. Given those potential complications, even if someone with Factor V Leiden hasn't had a clot, what lifestyle things might be most important for them to focus on?
That's a great thought. Beyond the obvious, like not smoking, I'd say staying active and avoiding prolonged sitting is huge. Good hydration. Maintaining a healthy weight reduces baseline risk. And being really proactive about discussing preventative measures before any planned surgery or long travel.
Yep.
Awareness is key.
Awareness and action. Okay, let's wrap this up. Key takeaways from our deep dive into Factor V Leiden for revision.
Okay, key points. Factor V Leiden, most common, inherited thrombophilia, caused by a specific gene mutation making Factor V resistant to its off-switch activated protein C.
The sticky switch.
The sticky switch
Mm.
increases risk of VTE, mainly DVTs and PEs, but many carriers are asymptomatic. Diagnosis is via APC resistance testing and hybrid or genetic testing.
Right.
Management is individualized. Anticoagulation mainly for those who've had a clot or during high-risk periods, not usually long-term for asymptomatic carriers. Lifestyle and awareness are crucial. Remember the potential odd benefits too, though focus on the clot risk. And the memory tip, Factor V equal fighting clots. Leiden means they're resistant to being stopped.
Perfect summary. Really important stuff to understand. That link between genetics and clot risk. Vital for anyone revising these topics.
Absolutely. And it does make you think, doesn't it, about that balance between our genetic blueprint and all the other environmental hits or lifestyle factors that ultimately determine whether someone actually develops a clot. It's rarely just one thing.
A lot to ponder there. Well, that brings us to the end of this deep dive. Thanks for joining us. If you are prepping for the MSRA, seriously go check out passmsra.com. Loads of great resources there.
Yeah, definitely worth a look. And also check out freemsra.com. More excellent stuff to help with your studies.
Until next time, take care and happy revising.